you all like it or not, okay, no matter how good you live or how much good you've done, we all will end up with aortic stenosis. Admit it, accept it, embrace it, okay? So, aortic stenosis, what is the number one cause? Age, okay? As we age, after the age of 65, 70, any patient you put the stethoscope on, you will hear an aortic stenosis murmur, okay? So age is going to be your number one cause. What's number two? You got a bicuspid aortic valve. Good. What's number three? I said mitral valve is the most hated valve by rheumatic heart disease. But you can hate more things than just one thing. What's the second thing rheumatic heart disease hates? It's going to be your aortic valve. Okay? So these are your three important causes. When it comes to aortic stenosis, let's try to figure out everything that's going to happen, right? So again, this is the heart, okay? Left atrium, left ventricle. And I'm just going to, I know that the aorta doesn't go in this direction, it goes in this direction. It just makes more sense for me to put it here. Okay, just in case people are wondering why am I anatomically drawing it wrong, right? So this is your aorta, right? So when it comes to aortic stenosis, clearly this aortic valve is going to be tight, right? So let's ask this question. We already know the causes. So obviously when you have a cause and you have a problem, you're going to present with symptoms. What is the symptom you're going to present with when you got aortic stenosis? You are going to become sad, okay? You age, you get old, you make sounds, and you become sad, okay? What do I mean by that? You become sad, you get syncope, you get angina, and you get dyspnea. That's all I meant. I didn't mean emotionally. Emotionally you can be very happy despite having aortic stenosis. But you will be sad because of symptoms. Okay? Now, knowing is not good enough. Understanding it is what matters. So, why syncope? Yes. So if the patient's got an aortic valve that's tight and you're not pushing blood out, remember, from your aortic arch comes your subclavian, your brachiocephalic trunk, all of those things, right? Which supplies blood to your head, your arms, as well as the rest of the body. So if you have less blood flow outside, you can cause syncope. And that's the reason for the first one. And number two, angina. Why that? What is your aortic valve got to do with your coronary arteries? What supplies blood to the coronary arteries? The early part of the aorta is what supplies blood to your coronary arteries, right? So if you have less blood coming through this, your coronary artery is also going to get less blood. If you get less blood flow through the coronary arteries, you get angina, and that's why. What about number three, dyspnea? If you're not going to push blood out, right, what's going to happen to the blood? It's going to have back pressure, and as a result, it's going to have back pressure. As a result, what's going to happen? You're going to get pulmonary congestion. And so you will end up with dyspnea. So that's why you're going to end up with the sad symptoms of aortic stenosis. Right? Okay. So these are your symptoms that you're going to expect. Now, when you come to examine your patient, because you know the symptoms, you're like, okay, I think this patient's got aortic stenosis, right? So from a physical exam standpoint, what would you hear in your patient? You would hear a systolic murmur. Great. Why? Because the blood flows through from the ventricle to the aorta during systole. Right? Okay. But does it happen early? Does it happen mid? Is it late? It is an ejection systolic murmur, which is going to be crescendo, decrescendo type. It's throughout the entire systole. So when it comes to aortic stenosis, your murmur is going to be an ejection systolic murmur. What else would you hear in this patient? And would it have radiation to the carotids? Yes. Typically you would listen to it in your aortic space with radiation to your carotids. Right? Okay. Now, what else is going to be an important feature to be present with aortic stenosis apart from that? Wide pulse pressure will be present more with aortic regurgitation. Right. What is pulsus, tardus, et parvis? What is this? It's a delayed upstroke of your carotid. So for instance, if you listen to your aortic stenosis murmur, and you listen to if you palpate your carotids, you should see the pulse when you hear the murmur. You should feel the pulse when you hear the murmur. But if there's a delayed uprising of your carotid, it tells you the patient's got aortic stenosis. So pulsus, tardus et parvis is a delayed upstroke, uprising carotid due to low flow state because of aortic stenosis, is pretty much diagnostic for aortic stenosis. Okay, so that's going to be another important feature for you to know. What else would you have from a physical exam standpoint? Is aortic valve part of your first heart sound or second heart sound? It's part of your second heart sound. Okay? When you have an aortic stenosis, and when you look at your second heart sound, you get A2 and P2. Okay? In aortic stenosis is a little different compared to mitral stenosis, where here, because it's so tight, your aortic stenosis, your A2 component is almost going to be silent. Okay? Because it's so stenotic, right, that it's not going to produce any sound, and as a result, your A2 component will almost be silent in the patient with aortic stenosis. It's going to be pretty much only P2 that's going to be heard. Okay? So soft to silent A2 is what you're going to hear, your pulses and your ejection systolic murmur. Now, with radiation to your carotids. Okay? Now, apart from that, of course, they're going to give you the maneuvers. So real quick again. Number one, let's do what happens to it on inspiration. Is aortic stenosis a right-sided murmur or left-sided? Left-sided. All left-sided murmurs will increase in intensity on expiration, would decrease in intensity on inspiration. So, should be low. And expiration should be elevated, right? Now, preload up versus preload down, right? If you have a preload elevation, meaning more blood's coming through the left side, you will have. So how do you define severe aortic stenosis? Very good. 1/440. So what becomes a surgical indication? Is having severe aortic stenosis by itself enough for surgery? Answer is no. Just saying it's severe alone is not enough. Number one needs to be symptomatic. That's pretty straightforward, right? Symptomatic, what are your symptoms? Sad symptoms. If you have a sad 1/440, you get surgery. We are calling this pseudo because it's something else. Calcification is making it seem like it's severe aortic stenosis, but it's truly not. So what you're trying to differentiate is pseudo versus real. So what are you going to do?
Dobutamine stress.
Good. You'll do a dobutamine stress echo. Now why is this going to help? Imagine if the patient, if you can give dobutamine and squeeze the ventricle, right? And if the chamber, if your aortic valve is still stenosed truly, it's going to cause that force to push and as a result raise the numbers, right? So if it qualifies once you do this, then your number goes above 4, and if your gradient goes above 40, then it says the patient's got true aortic stenosis. But sometime when you do the dobutamine, everything would normalize, and in fact, your aortic valve area would look like it's also greater than 1. Meaning it's just pseudo. It's not. Now, so this is important for you to know. Okay. Another important question is, imagine a patient had severe aortic stenosis based on echocardiogram findings. You do an echo, the patient's got severe aortic stenosis, meets and everything. But the patient is not symptomatic. Not symptomatic. Like, okay, how come you're not symptomatic? Everybody else is symptomatic, right? What do you want to do? You could do a TEE in most of these patients as a test after echo just to look at it more deeper, but no, it's not. You want to see if the patient is going to become symptomatic. You want to do a supervised exercise program. So while the cardiologist sits down there and watches this patient, you get them to exercise. and you're going to see if this patient is developing symptoms, right? If the patient becomes symptomatic, okay, such as sad symptoms, syncope, angina, dyspnea, right? Or if the patient is having EKG changes, okay, or if the patient is becoming hypotensive, this means the patient, based on your supervised exercise program, is truly symptomatic. Even though he's telling you he's not symptomatic, truly this patient is in fact symptomatic. Okay?